Hello, I'm Dr. Mark Sosinski. I'm the Executive Medical Director and a thoracic medical oncologist at the Advent Health Cancer Institute in Orlando, Florida. This short video presents 32 recommendations identified by the Expert Steering Committee to improve quality of care in non-small cell lung cancer management from our poster defining high-quality non-small cell lung cancer care at U.S. cancer centers. As previously mentioned, the recommendations are summarized into 4 key areas: diagnosis and biomarker testing, staging and treatment planning, care coordination and patient education, and survivorship. Around half of the recommendations focus around diagnosis as a key area for improvement. As such, it is recommended that low-dose CT screening services should be made available for select high-risk and former smokers, and smoking cessation options should be made available for all interested patients. Moreover, all suspicious findings should be evaluated by a team, including specialties of thoracic radiology, pulmonary medicine, and thoracic surgery as determined by the anatomical location of the node. Similarly, decisions regarding optimal diagnostic steps and biopsies and fine needle aspiration or collection of adequate tissue should be made by the multidisciplinary team. For stage 1 and 2 and 3A disease, patients should undergo invasive mediastinal staging. The pathologist should establish the histologic subtype after ensuring that enough tissue is available for molecular testing and programmed death ligand 1 or PDL1 testing where appropriate. Moreover, a plan should be in place to perform a rebiopsy and/or plasma testing if additional tissue is necessary to complete the workup. Determination of surgical resection, surgical staging, and pulmonary resection should be carried out by a board-certified thoracic surgeon with experience in lung cancer surgery. During surgical resection, at least 6 nodes should be removed, 3 each from the N1 and N2 stations. Systemic staging should be carried out using FDG PET CT scan in combination with brain MRI with contrast, and clinical staging should be carried out in line with the recommendations from the latest version of the AJCC staging manual. In the case of advanced or metastatic non-squamous lung cancer, testing for epidermal growth factor receptor or EGFR, anaplastic lymphoma kinase or ALK, CROS oncogene 1 or ROS1, proto-oncogene BRAF or BRAF mutations, and PDL1 expression should be included as part of the broader molecular profiling, including emerging biomarkers for which effective drugs may already be available. Testing should also be considered in non-smokers in the case of advanced or metastatic squamous cancers. Similarly, ROS1 and BRAF gene testing should be considered for small biopsy specimens or in specimens with mixed histology. In addition, processes to minimize the turnaround time for all biomarker test results should be instituted, and results of all biomarker tests should be taken into consideration prior to making any shared clinical decisions. Cell-free or ctDNA testing should not be used in lieu of a histologic tissue diagnosis. It may be considered only in specific circumstances. Considering the second key area of care, treatment, a care plan compliant with the 13 components in the Institute of Medicine Care Management Plan, including palliative care, should be provided to patients prior to receipt of the first therapeutic modality. For radiation therapy, determination of the appropriateness of radiation should be made by a board-certified radiation oncologist with experience in lung cancer radiation therapy. Dose escalation beyond 60 gray during combined modality concurrent chemoradiation may not have clinical benefits. Chemotherapy and radiation should be given concurrently to maximize survival, local control, and disease response rate. For patients with stage 4 non-small cell lung cancer, routine use of concurrent thoracic chemoradiation is not recommended. Neoadjuvant chemotherapy or concurrent chemoradiation should be offered to select patients diagnosed with stage 3A disease. Adjuvant chemotherapy should be considered for patients with high-risk stage 1B and 2B disease and offered to patients with resected stage 3A disease. In definitive concurrent chemoradiation followed by durvalumab should be offered to patients with unresectable stage 3A, B, and C disease. Importantly, overall treatment should be guided by genetic testing wherever applicable. In terms of care coordination and patient education, all patients should receive care navigation as standard care and participate in shared decision-making with regard to their comprehensive cancer care plan. Moreover, all patients should have access to a member of the multidisciplinary cancer care team who can answer questions regarding the financial aspects of their treatment plan. Finally, implementation of standard protocols for short and long-term surveillance and provision of survivorship care plans to all patients diagnosed with advanced non-small cell lung cancer are recommended to improve quality of survivorship. We believe that these 32 recommendations define ideal quality care in non-small cell lung cancer management. Thank you for watching this video.